We got a hot coffee here.
Just avoid any dust storms out there.
Sure, this was easy.
Well, no, not here. You didn't hear about that bad dust storm?
No. Oh.
Anyway. All right, thank you, everybody, for coming. We have a great speaker tonight, Dr. Elkhatib.
Hi, everyone.
He is an expert in acid reflux and many other things. He grew up in Ohio. Anybody here from Ohio? He received his Bachelor of Science degree in biology from Ohio State University in Columbus. After graduating from the Ohio State University, he attended medical school at University of Cincinnati College of Medicine, where he received his medical degree with AOA honors, graduating in the top 5% of his class. Pretty impressive. Spent a lot of time studying, I'm sure.
Too much.
He then, but that's good for us, thank
Right.
you. He then went on to complete his internal medicine residency at the prestigious Northwestern University, which we all know here in Chicago. While completing a rigorous core internal medicine specialization, Dr. Elkhatib received several resident teaching awards and the Humanism in Medicine Award. Most importantly, he fell in love with Chicago and all of us. And how could you not, right?
Right, no?
Dr. Elkhatib went to complete a subspecialty fellowship in gastroenterology at the University of California, San Diego. I just got that from you.
Oh, wasn't that?
During his fellowship, he authored and published multiple publications in esteemed gastrointestinal journals. He also authored 3 book chapters in separate popular gastroenterology textbooks. After observing the benefits endoscopic interventions could have on his patients, Dr. Elkhatib completed an additional sub-fellowship in advanced and therapeutic endoscopy at the University of California. He became skilled in endoscopic ultrasound, biliary procedures, enteral stenting, and radiofrequency ablation of Barrett's esophagus, among several other endoscopic interventional techniques. I'm glad that's done. It's a lot of. Thank you very much.
No,
Greatly
thank you for
appreciate you
having me.
speaking to us,
All right.
and enjoy.
Great. Okay. Hi, everybody.
Hi.
I'm seeing a couple of familiar faces and a lot of new faces. These are some of my favorite talks to give. I've been doing this for a couple of years now. I've been in practice in the region for about 10 years. And these talks here, these community talks are some of my favorite to do. A lot of times we get patients that are here taking time out of their own day, taking time from their families to actually learn more on their own for themselves. And I like to make these very informal. I like to make these very open to conversation, questions. A lot of us know how hard it can be sometimes to ask the questions we want to when we're seeing our doctors. Sometimes we get a 10-minute visit and we always feel rushed, and as horrible as that is, it can sometimes be really hard to ask the questions that we want to about some common conditions that we deal with on a frequent basis. I'm going to start with a couple of caveats. One, my voice is cracking, not because I'm going through puberty, okay, but I'm recovering from a cold from about 2 weeks ago, so I do apologize. And also my disheveled appearance. I have a 2-week-old at home, and so I have forgotten how little they sleep. Okay, so if I'm mumbling or anything like that, someone just give me a signal, okay? So you know, this topic of GERD or acid reflux, I think, is a really important one for a couple of reasons. One, in that it is so incredibly common. A vast majority of us at one point in our life will deal with heartburn or reflux disease. And the spectrum of how that can present is pretty wide. Some people have once in a blue moon issues with reflux if they eat something. Other people really suffer from this on a daily basis, enough to the point where it's actually significantly decreasing their quality of life. And, you know, we talk about heartburn because it's so common. Sometimes we'll just kind of, you know, just glance over it. But heartburn can be a serious condition and can lead to some significant health issues. And so I think it's really important to have a good grasp of what exactly heartburn and reflux disease is. What are things that we can do to maybe try and prevent it? And then talk about some treatment options. And one of the things I wanted to focus on and kind of bring up is some options that we have available now to try and get us off of medications. Because we live in an era where there's a med for everything. And sometimes that can be very daunting to have to be on a medication lifelong, especially if these medications may have some side effects. Okay, so that's sort of the intro here. And at any point, if anybody has any questions, please just jump in. I have a handful of slides, but I wanted to leave ample time also to, sort of discuss, at any point, including at the end. So, heartburn sort of has a couple of different presentations. An example here is, this gentleman, with the jacket on, he complains of heartburn maybe once or twice a month. He knows what triggers it. If he has a pizza or if he has some spicy foods, when he has it, he pops a Tums and he feels better. On the, other end of the spectrum, we have this gentleman here who complains of heartburn on a daily basis. It doesn't matter what he eats. He's going to have heartburn, and it's going to occur usually in the evening for him. He does get relief when he takes some medications, but he's been having these symptoms now for 10 years, and he's noticed that, hey, the Tums or my Gas X and things like that are no longer working like they used to. So let's kind of talk a little bit about what gastroesophageal reflux disease is. So when we talk about heartburn is actually a symptom. Okay, the actual true diagnosis that we're dealing with is actually called GERD. Okay, which you're probably all familiar with. GERD stands for gastroesophageal reflux disease. That is the disease that causes the symptom of heartburn, among some other symptoms. And what exactly is happening when we talk about gastroesophageal reflux disease or GERD? Well, essentially, the contents of your stomach, which are highly acidic, are moving sort of backwards or upwards into your esophagus instead of moving down and towards your small bowel. So you're refluxing backwards your stomach contents. And that's what GERD is. And so if you look at this diagram here, this is sort of a picture of the stomach, and it sort of highlights a couple of really important anatomic structures. Because to really understand reflux disease, we're going to have to understand the anatomy of the stomach and the esophagus. So as you know, the esophagus is the tube that connects your mouth to your stomach. It goes right behind your chest. The esophagus is the area where our pain and where our symptoms are coming from when we have heartburn. The acid contents of the stomach are refluxing through this very important junction. I'll go into this in a little bit more detail in just a second. But the stomach contents are refluxing through this very important gateway here. This is called the lower esophageal sphincter, okay, or the GE junction, okay? This gateway in normal functioning anatomy is fantastic. It stays tight when it needs to, and it prevents anything from moving upward into the esophagus. So with gastroesophageal reflux disease, this gateway, and I'm going to harp on this a lot because it has a lot of implications when we talk a little bit about some of the procedures we can do to fix reflux. In GERD, this gateway is incompetent. I know that sounds harsh, right? Like your sphincter's incompetent. No, incompetent means it's relaxing when it shouldn't relax. It's not staying tight when it should stay tight. And when that happens, contents that are in the stomach go up into the esophagus. The stomach is built for acid. It's thick. The lining is evolved to withstand acid levels of a pH of 2. So the acidic environment of the stomach is incredibly acidic. And the stomach is built for that. The esophagus, on the other hand, is not. The esophagus is a much more thin line structure, and it's much more sensitive. So if acid gets up into the thin line esophagus where it's not supposed to, that's going to cause some problems. And one of those problems is heartburn. So what are the other symptoms that can occur with gastroesophageal reflux disease? I know we talk about heartburn because that's the most common, but as many of us here who probably suffer from GERD can attest, there's a bunch of other things that we oftentimes feel. Regurgitation is a big one. That means that you're feeling food kind of move up. So things that you just ate or ate not too long ago, you're actually feeling them come up. Sometimes they'll actually make its way all the way back up into your mouth. That's called regurgitation. Chest pain. Sometimes people will have a pain in their chest that almost mimics a heart attack. Patients will think they're having a heart attack. They go to the emergency room thinking they have a heart attack. And a lot of times they'll get their cardiac workup and find out that their heart is fine and it actually is GERD. And so chest pain is something that we see a lot. Chronic cough, this is sort of one that's maybe a little bit less common, but reflux can actually be a cause of a dry cough that just doesn't seem to go away, especially a cough that tends to be more significant when you're lying flat. And that's because acid reflux, as it works its way up, sometimes actually makes its way down to your mouth, and then you can actually aspirate. And so you're actually getting acidic contents sort of irritating your vocal cords, which will cause hoarseness, irritate your lungs, which can cause the cough. So some people actually have a cough from reflux disease rather than like a pneumonia or a bronchitis or things like that. Bad taste in the mouth, bad breath. It can be a cause of problems with dental cavities, from or dental damage from the acid as well as bad breath. Wheezing, again, from the acid going into the lungs. And then there's something called pain with swallowing. So when they eat food, it actually hurts. They feel it. Patients will tell me, I had that bite of food and actually I feel it as it comes down. We're not supposed to feel our food when it goes down. So when you feel it and it hurts, that could be a sign of GERD. And then sometimes, and this is kind of a red flag, is, the sensation of food getting stuck. So in addition to, or as opposed to food hurting on its way down, you eat, and you feel that it's kind of taken a long time to get down or it gets hung up. That's called dysphagia. That's a very important symptom if you have that requires attention, and we'll talk about that. Sometimes people feel nauseous. Sometimes people have a lot of belching. So there's a lot of symptoms that reflux disease can cause, not just heartburn. And in fact, some of these other symptoms are more problematic to patients than the heartburn itself. So those are the symptoms that reflux can cause. But there's also some conditions that reflux can cause, or what we call complications. So the acid exposure over time in certain individuals can actually lead to damage to the lining of the esophagus. That's called esophagitis. And I'll have some pictures here in just a second. Esophagitis means ulcers of the lining of the esophagus. Peptic strictures, that means that scar tissue from repeated acid exposure to your esophagus actually results in narrowing of your esophagus. Your esophagus gets tighter, and that's where things like food can get stuck, start to come up. Barrett's esophagus is very important. We'll also touch upon that a little bit here. This is sort of one of the feared complications of reflux, in that the lining of the esophagus starts to try and transform to protect itself. And unfortunately, that transformation can lead to cancer, or cancer of the esophagus. So right now, the top cause of esophageal cancer is Barrett's esophagus in this country. It used to be smoking. Now it's Barrett's esophagus, which comes from acid reflux. And then, like I talked about, you can start having things like asthma diagnoses, as well as problems with your teeth. All of these are complications from reflux. So there's issues that it can cause aside from just those symptoms. And like I touched upon earlier, GERD is a big problem. Okay, I mean, this is 1 in 5 people in this country suffer from reflux disease. Think about that. That's huge. Okay, and we have almost 20 million patients taking medications for reflux disease. Okay, of these patients with reflux disease, about 15% may develop that Barrett's esophagus that we talked about and have a 40-fold increased risk of cancer. So this is a big problem. So again, I want to just kind of put a little bit of focus here on the anatomy, because it'll make so much more sense as we talk about things that we can do to prevent reflux if we understand the anatomy. So this is another picture of your stomach and your esophagus and how they connect. This gateway here that we're talking about, right here, okay, this is the very important gateway that prevents the acid from coming up. It's composed of a couple of different things. One is composed of your diaphragm. So the diaphragm usually separates your stomach or your abdomen cavity from your chest, and your stomach is below your diaphragm, and then your esophagus is above your diaphragm. And so that diaphragm actually is part of this gateway. You also have a muscle here called the lower esophageal sphincter, which is also part of that gateway. These two together form that gateway. And so if we have anything that sort of impacts this gateway, we're going to have problems with reflux disease. If you've noticed, I haven't mentioned anything about making too much acid. This is a common misconception. When we have heartburn, we're not making too much acid. When we have GERD, a lot of times we're making just the right amount of acid, or maybe even sometimes we're making less acid. GERD is not a problem of too much acid. It's a problem with the acid that you do have working its way up, okay? So that's a really important concept here, okay? So this is just a close-up view of what that sort of gateway looks like. So let's say we take a camera, like an endoscopy, which is what we do. We go down your mouth through your esophagus, and we look at this gateway sort of head on. This is what we're going to see. We're going to see what kind of looks like a little sphincter, a little kind of pinhole there when it's closed. And then when it opens, it sort of opens. You see sort of a nice opening, usually about the size, about 12 to 15 millimeters. But that's sort of the view that we see of this lower esophageal sphincter, okay? So what makes this sphincter weak? What makes our gateway incompetent? Well, there's a couple things. We'll talk about them now, all right? So the thing that we all comes to the forefront of our mind is food, right? Because a lot of times reflux occurs after we eat. Food is a big trigger of some of our symptoms. So food is always at the top of the things that we talk about with reflux disease. And there are certain foods that actually loosen or force relaxation of your lower esophageal sphincter. So the most common things that we talk about are things that you probably know. So fatty foods, chocolate, and there's a lot of good stuff on this list, okay? Carbonated beverages, red wine, okay? Garlic, peppermint, onions. These are foods that actually relax your sphincter. So we'll talk about some other foods that actually do make you make a little bit more acid, but these foods are part of what we call the GERD sort of no-nos, and we ask our patients to really limit these sort of foods. The sphincter, though, can also be weak because of a family history. Some people will say, oh, my parents have the same thing. They suffer with reflux just as badly as I do. And so there's some genetic component to potential weakening of that sphincter. As we get older, that sphincter does tend to get a little bit less strong, okay? So with wisdom comes a weak lower esophageal sphincter. So as we get older, sometimes this becomes more of a problem where it wasn't, in the past. And then there's a big thing here called a hiatal hernia. Have you guys heard of a hiatal hernia before? So a hiatal hernia, we'll talk about that here in just a second, but this is a big cause of an incompetent gateway. And a hiatal hernia, let me see that, yeah. So a hiatal hernia essentially refers to part of your stomach being pulled up above your diaphragm. So remember we said that the stomach predominantly resides below the diaphragm. When you have a hiatal hernia, imagine someone just kind of grabbed your esophagus and just pulled everything up, and part of your stomach goes above your diaphragm. The part of your stomach that's above your diaphragm is called the hiatal hernia, okay? And you can have small hernias, or you can have huge hernias. Some people have half their stomach above their diaphragm, or their stomach sitting in their chest. Most people have a small one, maybe 1 to 2 to 3 centimeters. Even a small hernia of that size is enough to make that gateway less strong, because now your diaphragm is no longer contributing to protecting your esophagus from acid. These are things that you might hear your doctor say when they're talking about, why your reflux is as severe as it is. Some other things that can contribute to the reflux
is obesity. If we have increased abdominal pressure, that actually makes it easier for the acid to work its way up. And obesity and tight-fitting clothes and pregnancy all fall into that same category. We have increased abdominal pressure, and that's pushing on our stomach. It's making it easier for acid to go up. That's why a lot of pregnant patients will say, gosh, I really have a lot of heartburn during this pregnancy. And that's because of that increased abdominal pressure. A small subset of us will have what's called gastroparesis, or delayed emptying of the stomach. Those are usually our diabetics, our patients with diabetes who have other sort of neuropathies. Their stomachs may not empty as quickly as someone without diabetes, and so it makes it easier for acid to work its way up, okay? So that's not very common. That's more just a small subset of patients, but that's something that can occur. Now, increased acid production only accompanies for a very small, or accounts for only a small percentage of patients with reflux disease. So what is going to make you make more acid? Well, one is large meals. So if we have a large meal, that large meal triggers the stomach to make a lot more acid in order to break things down, and it also fills the stomach more, and that makes it much more prone for acid reflux. Certain foods, mainly these three here, tomato-based foods, so your red sauces on your pastas are big, big culprits, citrus foods and spicy foods. These, as opposed to the other foods that I mentioned, actually work by really increasing the amount of acidity that's in the stomach and plays a role in the reflux disease. So these are some sort of causes of reflux, okay? So causes of that incompetent lower esophageal sphincter. Sort of the foods that we're eating, abdominal pressure that we have, whether or not we have a hernia or not. These are the three sort of big sort of things, in addition to factors that we just don't know. Some people don't have any of these and they still have reflux, but these will account for the majority of our patients. So how do you know if you have gastroesophageal reflux disease? So what are the tests that we use for patients with reflux disease? Well, vast majority of the time, we don't need a test. It's pretty clear, just based on the symptom description, if you have GERD. So for example, if you say I have a burning sensation in my chest, usually occurs after I eat pasta, goes away when I take medication, you don't need a fancy scan or anything like that. That's reflux disease, okay? Now, sometimes it can be a little bit trickier for patients with some of those other symptoms we talked about, like the chronic cough or the hoarseness, or people who have chest pain, okay? Sometimes it's a little bit less tricky. So what a lot of doctors or your primary care doctor may do is what's called a treatment trial. If you have a symptom that sounds like GERD, let's try a treatment that only works predominantly for GERD. And if you feel better, it's probably GERD, right? So that's what's done most often. Now, in patients that have symptoms that may not fit completely, or patients that maybe don't respond to the medicines like we would expect, or patients who have what we call red flag symptoms, okay? Those patients are going to get an upper endoscopy, okay? Just a show of hands, has anyone here ever had an upper endoscopy or a scope? Oh gosh, okay, so the majority. So very familiar, very common test, and I think I'll talk about it here, yeah. So the upper endoscopy is almost considered the gold standard at looking for complications of reflux disease. It also looks to see if there's any issues in terms of a hiatal hernia or something anatomic that can contribute to your reflux disease. And this is when your gastroenterologist will take a camera. It's a fiber optic flexible tube with a high definition lens on the tip of it. And then we have a big screen. We put you to sleep first. And then we go down your mouth like you're swallowing a noodle. And on that screen, we're going to get direct views of your esophagus and of your stomach. And we're going to see if we find any ulcers, any hiatal hernias, any issues. This is one of the most important tests, or one of the more important tests for reflux disease. Okay. Now, the endoscopy that I mentioned, while looking for complications, it doesn't actually directly measure how much acid is coming up into your esophagus. So in some select cases, when it's still kind of questionable whether or not you truly have gastroesophageal reflux disease, we have a test that actually measures how much acid is coming into your esophagus. And that's called a pH study. And there's a couple different ways to do that, but the most commonly done way is through a scope where they deploy a little capsule called a pH capsule, which stays onto your esophagus, and you carry a little recorder. It's a little purse with a little recorder. And every time you have a symptom of heartburn, press a little button on that recorder. And then usually after about 48 to 72 hours, you give us that recorder back. And we have a wireless transmission of all the acid exposure from your esophagus to this little box. And we can correlate your symptoms to the level of acid. And so in some patients, you'll get what's called a pH study. These are really the main players when it comes to making that diagnosis of GERD, or gastroesophageal reflux disease. This is that pH study that we talked about. I don't know if any of you have had this. This is less commonly done, but when we go down with the scope, where this is one of our options, the most commonly used one is called a pH Bravo. We're actually deploying a little wireless transmitter, which attaches to your esophageal wall and transmits wirelessly to this little box that you're going to carry around like that. And this capsule then falls off by itself. Okay, usually a couple days later, it'll just fall off and you'll just pass it in the toilet, like when you go have a bowel movement. You don't have to retrieve it. Okay, so you won't be sifting through there. Okay. So how do we approach, our patients with GERD? Well, like I said, most of our patients who have the symptoms, we're going to go across a level of. Oops, let's see if this moves forward here. Okay. Most of the people who have GERD, we're able to manage with just dietary changes, lifestyle changes, and then, potentially some medications. There's a few patients that have sort of red flag symptoms or aren't really responding to therapy. Those are patients that we're going to do some of those other tests, like the scope or the pH study. And then those patients who have truly diagnosed and confirmed reflux disease that aren't responding to medications, that's when we start to talk about, some other steps like surgery. And we're going to talk about that here in just a little bit. Okay, so let's jump in here a little bit to the managing the reflux. So we already went over some of these here. I want to go over those in a little bit more detail. Here. Okay, so we already know this. People with reflux disease, the symptoms can be very significant, really reduce the quality of life. Patients who have reflux at night in particular can be really problematic. These patients are sometimes waking up in the middle of the night, gasping, severe pain, having trouble sleeping. And that then in essence leads to less productivity at work during the day. They're very tired. So nocturnal reflux can be significantly debilitating. And these are patients that really are sometimes at their wits' end looking for ways to get some relief. So this is a little triangle here when we talked about with acid reflux. We have sort of the symptoms of acid reflux, but also the complications of acid reflux. And that's what we're going to look at in the next couple of slides. So this is what it looks like if you have what's called esophagitis. If your acid reflux is severe enough where it is actually causing damage to the lining of your esophagus, that's called esophagitis. And what you have is essentially ulcers of your esophagus. And these ulcers can be small, they can be large. The bigger the ulcers, the more painful it is for the patient. And people who have GERD that causes esophagitis, those are patients that are at the highest risk for then going on to develop those narrowings that we talked about or the cancer. These are patients that dietary changes are not going to cut it. Lifestyle changes are not going to cut it. These are the patients that really do need something more aggressive, like a medication or a procedure, because this is more than just run-of-the-mill reflux. This is what's called a peptic stricture. So this is a picture of the esophagus. And I don't know if you can appreciate this, but this area right here is narrowed. Okay, I wonder if I have a, so see how, this is kind of the normal opening here. This is a ring or a narrowing. That's called a stricture. And that's from scar tissue and swelling from the acid reflux. causing the esophagus to have a narrowing, and that's when food can start to get stuck. If anyone has had food stuck in their esophagus, I have. It's a horrible feeling. Okay, nothing gets rid of that pain. It is extremely anxiety provoking, and sometimes people feel like they're maybe choking. It's a horrible feeling, and until that food passes, there's not a pain medicine on the world that will make this go away. So food getting stuck can be a real big problem, and that can be a sign of this peptic stricture. So the third complication is Barrett's, okay? Barrett's esophagus is getting a lot of headlines because, again, it is now the one of the most common causes of esophageal cancer. And this will show up when we do the scope as a change in the lining of the esophagus. So you see that sort of salmon-colored mucosa, or salmon-colored lining there. That's the Barrett's esophagus. So what's really happening there is your esophagus is trying to protect itself from all that acid that keeps hitting it over time. And so it starts to transform into a different type of lining. That's called metaplasia. And while in theory, that can protect your esophagus from the damage of acid, what can happen though is that transformation can sort of sometimes get unregulated or dysregulated. And then it makes you more prone to forming cancer. So the Barrett's itself, it's not anything that you feel. Nobody feels if they have Barrett's. Barrett's is silent, all right? But it's a change that tends to occur in patients with long-standing reflux disease. And the only reason we care about Barrett's, since it doesn't cause any symptoms, is that it's a precancerous lesion. Barrett's esophagus can lead to esophageal cancer. So not everyone with Barrett's goes on to form esophageal cancer. The patients who have a Barrett's esophagus that is long and has what we call dysplastic changes, they have a much higher chance of going on to form esophageal cancer. People who have Barrett's without any of these changes, the risk of them going on to form cancer is felt to be maybe less than 0.5 percentage point. Okay, whereas people who have Barrett's that's quite extensive or more advanced, that's called dysplastic Barrett's. They have sometimes up to a 30% chance of developing esophageal cancer, which is crazy high, which is very high. So when we find a patient who has Barrett's esophagus, okay, we want to make sure that we know that so that we can watch these patients and potentially eradicate their Barrett's esophagus so that it doesn't turn into cancer, okay? This is kind of what a cancer of the esophagus would look like. If you're taking a camera down there, it looks like an apple core type lesion of growth in the esophagus. It's usually very friable, meaning it loses blood and it makes the esophagus narrow or tight. So I won't go into this in too detail. This is just going over, esophageal cancer. That's sort of beyond what we want to talk about here. But okay, so let's jump into the treatment aspect now. So step number one is dietary modification. This is always the first thing that we go to. And in probably about 70% of patients, this may be sufficient. If you're the infrequent reflux patient, this may be all you need to do is watch what you eat. These are the foods that make that list. Some patients this may not apply to them. Some people with reflux may say, "Doc, I can pound, 3 truckloads of Godiva and chocolate and I don't have any reflux." And other patients will say the same thing about spicy foods, But these are the main triggers that we will put on what's called a GERD diet.
Fruits.
So not all fruits, you're right. That's kind of a catch-all, but mainly going to be your citrusy based fruits. Thank you. So fruits, chocolate, alcohol, caffeine, fatty foods, tomato-based foods. In my experience, the biggest ones are going to be your red wines, your tomato-based foods, and your alcohol. In my experience, those tend to be some of the biggest triggers. Some people will have foods that aren't on this list that they say, this will definitely give me reflux, okay? Lifestyle modification is often also recommended at the same time of the dietary changes. Weight loss can make a big difference because weight loss decreases that intra-abdominal pressure. And if you have a hiatal hernia, it actually can get that hiatal hernia to potentially regress. Avoid tight-fitting clothes. So a lot of times, people unknowingly, are wearing clothes that are putting a lot of pressure on their bellies. And that can actually increase your abdominal pressure without you knowing it. And avoid eating close to bedtime. Why is that? Well, when we eat, that's what triggers the acid production. And if we are just had a meal, that's when our stomach is most filled with acid, fluid. And when we lie down, gravity starts to work against us. When we're lying down, the fluid and the acid that's in our stomach, it's much easier for it to reflux sort of into the esophagus when we're recumbent rather than when we're upright. So it's simple gravity that plays a role in this recommendation of don't eat before bedtime. So we usually recommend at least in severe cases, more than 2 hours after you eat, do not go to bed. So if you eat, wait at least 2 hours before going to bed. And that can be a big factor here. Along the same lines of the gravity approach, sleep with the head of the bed elevated. Because you're, again, lying down and the acid can go up, if you're putting yourself at a 35-degree angle, you can help clear that esophagus with the gravity, with your own saliva, which helps neutralize acid. All of that's much easier. Sometimes it's as simple as just stacking up a couple of pillows. Sometimes you can, cough up the cash for some fancy GERD pillows that they have out there. I've looked at some of these. Some of them are really expensive, and but
Is my pillow one of them?
well, my pillow, I don't think they have a GERD specific pillow. I'm not sure if they
have something
do.
like that?
They do. Oh yeah, they have certain companies that just make GERD specific pillows
How do you
where
get that?
online, yeah, you can order them. I think this is a company that actually makes beds that will tilt up. Okay, some people have beds that you can control the head, and so yeah, so that's specifically for reflux patients. But the pillows, they just they try and make it so that there's spaces that you could put your arm through, as well as get propped up. So they're kind of they have some fancy things to do, just make it more comfortable for you to sleep on an elevation. But this combined with the avoid eating close to bedtime can dramatically improve your symptoms, especially if you're someone who has symptoms at night. Okay, so that's the food, that's the lifestyle modifications, okay? And then sort of the medicines come up. So we're probably all familiar with medicines for reflux disease and probably have all used some at one point in our life. Medicines for acid reflux are broken down into 3 categories, and they're in an increasing strength here, okay? So this is the least powerful to the most powerful. So antacids, what falls under that category? Well, those are your things like your Tums and your Rolaids and your Pepto-Bismol. Antacids work by neutralizing the acid that's already produced and already in your stomach. So they work as trying to neutralize the acid. So acid's already there. We're just taking this and it tries to neutralize it so that it's less acidic. Antacids are great for patients that have infrequent symptoms and want kind of immediate relief, and that their symptoms aren't too severe. So these are patients that, okay, I just had a pasta, I don't feel good, let me pop a Tums. You usually can get relief within 15 minutes if in many patients, not all patients. So for mild reflux, infrequent, dietary triggered, this is probably your best approach, in addition to all those other things I mentioned, is just have some Tums in your pocket or some Rolaids or whichever of these work, okay? There are some risks with these medications being taken too frequently. Tums, for example, contains calcium carbonate, and sometimes that can increase your risk of kidney stones, as well as if you have any kidney issues, it can cause some electrolyte balances. So just because they're over the counter doesn't necessarily mean that they're entirely safe, but in general, very well tolerated. Next category of medications is called your histamine 2 blockers. H stands for histamine, and that's because histamine receptors play a big role in your production of acid. And so these medications are things like your Pepcid, your Zantac, your Tagamet, Pepcid being the most commonly used one, or famotidine, okay? These medications are fast acting, usually within 20 minutes, okay? They are more powerful than your antacids in terms of symptom control, And they are a great option, again, for patients that not necessarily have daily symptoms, but maybe symptoms that are more severe than what Tums or Rolaids can handle, okay? These medications can be taken once or twice a day. Again, they're relatively safe and very well tolerated for the most part. Some people can have side effects of urinary retention with these histamine blockers. So something to kind of keep in mind. Then that brings us to now the most commonly used class of medications for reflux, which are the proton pump inhibitors. And these came out about 30 years ago or so, and have really revolutionized how we treat acid reflux as well as ulcers. And these actually work by preventing the acid production in the first place. So we're not neutralizing the acid anymore. We're just telling our stomach cells to not make as much acid. And so that's what makes these super effective. And there's a whole host of medications that fall under this category, many of which that you've seen. These are just a few that are listed up here. And in general, all the medications under this class are relatively comparable in their effectiveness. So it's rare to say one maybe works better than the other. There are some exceptions. You know, Acifex is a little bit stronger than the Prilosec, for example. I don't have on here pantoprazole, which is the one I use most commonly, but these all fall under the same category. Oops. And so these medications do not work immediately. These take time to work. And so these are best for patients that have frequent symptoms, like more than once or twice a week, where they need to preemptively control their symptoms by taking this medication. These have to be taken on an empty stomach or they won't work. If you've already eaten, the acid is already there. And so these won't have as much of an effect. You have to take them 30 minutes before a meal so that you can prevent the acid from being made in the first place, okay? These medications, if taken correctly, can actually increase the pH of your stomach above 5, which is really good. And they're very, very effective. Now, move over to this next. These PPI medications, or proton pump inhibitor medications, are getting a lot of press because, first of all, these are among the top 3 most prescribed medications in the country, in the world. Overall, they're extremely safe, but there are some risks that come with these medications that start to surface if we're taking them long term, okay? The higher the dose and the longer we're taking these medications, the higher the risk of some of these potential complications. One is low bone density. We start talking about things like osteopenia. We're not 100% sure if that's truly a risk, but you know, it's enough where we're thinking it may be. Low magnesium, we're pretty sure that it can cause low magnesium. SIBO stands for small intestinal bacterial overgrowth. We can sometimes have bacterial overgrowth because the acid is no longer competing, and that can lead to bloating and discomfort, sometimes diarrhea. And then low B12. There's some other theoretic risks which haven't been proven, but these are getting a lot of press. The big one is dementia, okay? There was a New England or a New York Times article saying that the increased risk of, you know, these medications in terms of dementia. Most experts and most gastroenterologists are very, very skeptical of that correlation. But my point here is that these medications, while effective, do carry some risks. So if there's a way to get off of these medications, that would be really, really nice to know. So who are the patients that, you know, usually want to get off their medications? Well, it's usually the patients that can't get off of their medicine, meaning they have heartburn, they do the diet, they do the lifestyle changes, they start taking the medicine, they get the scopes, everything, and they feel great. They take the medicine for a month, maybe 3 months, and then they try and go off the medication. And when they do that, they find that the symptoms come right back. They repeat the cycle, go back on the medicines, wait a little bit longer, and then they try and get off, and the symptoms come right back. These are patients that are what we call PPI dependent, meaning they're dependent on medications to get relief. And so when I have a patient that comes in who is 25 years old, 30 years old, they tell me, Dad, do I have to be on these medications for the rest of my life? It also applies to people in their 50s, and their 60s, and their 70s. Taking a medication for the rest of your life that has potential for side effects, albeit very rare, can sometimes be, an issue. So what do we do what do we have to offer these patients? Well, all these medicines that we talked about, if you noticed, none of them are really treating the underlying problem. None of these that I mentioned do anything with that gateway. They don't do anything to tighten that sphincter. All they're doing is getting rid of the acid so that when you do have reflux, it just doesn't hurt. It doesn't cause damage, okay? But it's not getting to the underlying cause. So when we talk about getting to the underlying cause, that's where we have these anti-reflux procedures. And these have now become more and more popular, and more people are turning to anti-reflux procedures as a potential option for them to get them off their medications. So when we talk about these anti-reflux procedures, there's two categories or two options: surgical or with the scope, okay? Endoscopic or surgical. Let's talk about the surgical ones real fast first. So first of all, does anybody have a surgery for reflux? Has anyone here had a surgery for reflux? No, okay. So the most common surgery is called a Nissen fundoplication, or a wrap. And what they're doing here, what the surgeon is doing, is they're actually tightening your gateway by taking the top part of your stomach and wrapping it around your esophagus, okay? And that's called a Nissen fundoplication. It's done with a surgery, which can be laparoscopic. And these can be very effective. And a lot of patients, once they have this done, no longer need their medications. The surgery itself, for the most part, can take, about an hour or so, depending on the surgeon and the volume, and if they're having to fix a hernia too. There are a couple of risks that come with a procedure or a surgery like this. One is that sometimes that wrap can be too tight. If they tie it too tight, food will have trouble going down. And patients will have what's called that dysphagia, where food is getting stuck. A lot of times we can fix that, sometimes by doing a scope and stretching it out, but sometimes even that does not work, okay? And I can tell you, I've had patients tell me, I will take my reflux, get this thing fixed, because I cannot have my food stuck every time I have food. I have to eat soups only and things like that. Thankfully, again, it's not very common, but it does happen. When it does happen, most of these we can fix with the scope, but there are some patients where we can't. The other is this gas bloat syndrome. So a lot of times when you have a wrap, you're someone who will no longer be able to burp, okay? So you cannot have that belch. When you can't belch, that can be a really problematic symptom, okay? Imagine feeling like you have air in there and you want to burp it out, but you can't, okay? So that's called the gas bloat syndrome. That leads then to bloating and discomfort. And these two things here are sometimes enough for a patient to say, no, thank you. I don't want to do that. This is a newer surgery. I don't know if anyone's familiar with this. We gave a talk about this a couple of years ago, and this is called magnetic sphincter augmentation device. This is a way that they tighten your sphincter, your lower esophageal sphincter, by using some carefully measured magnetic beads, which is pictured down there. They will measure the size of your esophagus, pick the number of beads that they need to put in there, which are on like a little string, and these beads are then put over the last part of your esophagus where that sphincter is. And the way these beads are designed is that they remain tight unless food is coming from above, then they relax or they open up, they separate. But when there's no food, they remain tight through a magnetic component preventing reflux. This surgery has some benefits or some pros. It's technically usually pretty easy to do from a surgical standpoint. The risk of that gas bloat syndrome drops significantly. So most patients with this are still able to belch, still able to have that sensation when they need to. And that risk of dysphagia or it being too tight is less because again, they kind of measure these before they put it down. You still can have a problem with this being too tight because you get some scar tissue. And so some people still have a problem with food getting down when they have this, but the majority don't. What are the other pitfalls of here? Well, we don't have long-term data. We've been putting this in for maybe about 10 years. So we have data for 10 years plus, but we don't know, what about that patient that's had that in there for 15 years, 20 years? We don't have as much information of long-term effects of having this sort of device in you for that long. This is also done by, like I said, by a surgeon. It's done laparoscopic and is the second most common surgical approach to reflux. So what about not surgery? So what about patients that say, I don't want to have that risk of food getting stuck or that gas bloat syndrome. I don't want to be operated on. I don't want an incision. Do we have any options? And the answer is yes. In a subset of patients, we have a scope that can perform an anti-reflux procedure. And this is kind of the reason I'm giving this talk, really, is to just introduce you guys to this procedure, which is called a transoral incisionless fundoplication, or TIF. This is done by a gastroenterologist most of the time, but also some surgeons also do this as well. And this is done through a scope, just the same scope that we use to diagnose you. We would use this to actually do the procedure. And essentially what we're doing is, through this technology, we're actually lengthening your valve, or lengthening that gateway. When we make that gateway longer, it makes it harder for acid to work its way up. And we can do this without having to do a wrap, without having to, take part of your stomach to, make things tighter. We're not doing anything that will risk getting the food stuck. So this has no risk of that dysphagia of food getting stuck. It also does not prevent your ability from belching. This procedure can be done in about 30 minutes. It's done under sedation, and it's done usually at skilled centers that have the expertise in this. In terms of the disadvantages of this procedure, we talked about the advantages. The disadvantages are it's slightly less effective. So this, if you're comparing it to the first surgery where they do the wrap, that's going to be a much more effective. In our studies, we see a higher percentage of patients able to get off their medications than we do with this. So patients right now who are getting this procedure, we find about 70% are able to get off their medications, but that does leave 30% who aren't able to get off their medications, which is a decent number, okay? This procedure, having it done, does not prevent your ability from getting a surgery later on, because there's no scar tissue that forms with this. So a lot of times this may be a good option for patients as a first step, for example, who don't want surgery, but keeping in mind that if it doesn't work, they still have options to then progress to something more aggressive. And that's called a TIF procedure. Any of these procedures that we have, in order to get them done, takes a little bit of workup beforehand. So not anybody who just has reflux can automatically walk in and just qualify for an anti-reflux procedure. The surgeons or the gastroenterologists need to make sure that you're a patient that would actually benefit from it. And they do that first by making sure that they've confirmed 100% that you do have reflux. So these are the patients that will get that pH study that we talked about. We will absolutely need to make sure you don't have a hiatal hernia, because if you have a hiatal hernia, that needs to get fixed. You wouldn't be a candidate for that TIF procedure unless that hernia is fixed. So the hernia, if it's present, really changes our management. So we do testing to confirm that you have reflux. We do testing to see if you have a hiatal hernia. And then the last part is we do testing just to make sure that your esophagus moves good, because there's a small subset of patients whose reflux is caused by their esophagus kind of not moving right. It's called a dysmotility. And these patients, if you get a wrap or you get any surgery, they don't do very well, okay? A lot of times, these are all done in the same day. The patient will come in the morning, we'll do the scope. At that time, we'll drop the pH study, and then they'll do the manometry at the same time. So these can all be done, all these tests can usually be done on one setting, but it is essential prior to any anti-reflux procedure, be it surgical or endoscopic. And then you'll have a consultation with your gastroenterologist or your surgeon once all these data are done, and they'll look over everything. They'll say, hey, I think this would be a good option for you. Or they might say, hey, I don't think this would be a good option for you. And then you can kind of move forward with your decision at that time. So we talked about the risks here, and just to kind of summarize here, and then we'll just kind of chat and open up to questions. GERD is one of the most common problems. It can result in multiple symptoms as well as multiple complications. The underlying problem is that lower esophageal sphincter, that gateway. It's not that you're making too much acid, it's just that your gateway is relaxing more than it should. Medicines are fantastic. They work for the majority of patients. There's different medications based on how frequent and how severe your symptoms are, and they work great. In some patients, the medicines are either not working well enough or they are dependent on these, and these are patients that should really consider talking to their doctor about anti-reflux procedures if it's a good fit for them. And at any point, if you guys have questions, this is my office, this is my email. You can email me directly. You can feel free to call my office and say, I want to talk to Dr. Elkhatib. My office is here in Oakland. For those of you who haven't been, we're on 105th and Cicero. I do procedures at a couple of different hospitals in our community, including Christ, including Mary, including Palos Hospital, as well as in our office. We have an office endoscopy. So we have a couple of options for our patients. For anti-reflux procedures, specifically that TIF, those would only be able to be done at the Advocate Christ or at Palos for the procedures that I'm doing. But let me stop there. All right, how did I do on time? Okay, all right. Question?
Yeah.
Yes.
There's two procedures, with the stomach wrapping around and like I'll call it a bracelet.
Yeah, it kind of looks like those.
Do
Yeah.
those ever loosen up and have to be done again?
That's a great question. Yes, yes, definitely. You can have a loosening of both the wrap, the magnetic bead, the links. That I haven't seen a lot of loosening of that, but I've seen it slip a little bit. So it sort of slips up a little too high. I've seen that happen before. But there are some people who need revisions of their wrap because it becomes loose. So it can happen.
And the stomach wrap too, that can loosen up and have to be redone?
Absolutely. Yep. I've definitely seen that happen.
Because I know of two people who went through, and I don't remember which procedure, and they said it was miserable.
Yeah,
It was really miserable afterwards.
it can be tough. Did they have problems with that gas float where they couldn't belch, or was it more like food getting stuck? Or-
I don't know exactly, but I don't know.
Yeah.
It sounds very good, so.
Yeah, sometimes patients can, especially, that's why it's really important to pick the right patient. If you have those testing that they do, will try and identify if you're at risk of having some issues. Especially, I've noticed people that have motility problems. If they get any of these procedures, they're not going to feel well, And so that's why that testing is meant to try and minimize the patients that we pick to do this.
I have to go back to work, sorry.
Okay, good to see you. Thanks for coming.
Does the one with the little beads cause a problem for any other kind of medical procedures or MRIs or CAT scans or anything because of the magnetic?
Yeah, that's a great question. Definitely not CT scans. You get a little card, I think for the airports. I think it's MRI conditional. I don't know the answer to the MRI though. I'm pretty sure it's MRI conditional, meaning depending on the type of MRI that they have, you can get it done. But I'm not sure. I'm not sure, but CTs are definitely safe.
Yeah, well, I just wondered, like, sometimes if the person goes to the emergency room or something, they don't know you have this.
Yeah, they, that's definitely important to tell them, but I'm almost certain that most of our newer MRI systems are okay with this.
And then are there other things that could cause the food to get stuff like that, or is this pretty much covered? Because my dad started having that and he's acting like, oh, it'll be okay, he's gonna deal with it. And I know somebody else that had something similar, and I'm trying to tell him that in the endoscopy, whatever, you just check that.
Yeah, I
It's
know,
benign and be easy, just go do it, but
food getting stuck.
there's not other things that you can cover that.
There are some other things. The other one is eosinophilic esophagitis. So there's a type of food allergy which can result in narrowing. Sometimes you can also have a little benign ring. It's called a Schatzki's ring, which is just scar tissue. But whenever food's getting stuck, that's never normal, and that always needs to get worked up because that can be the first sign of that cancer. food getting stuck.
Yeah.
So if anybody has that, it always warrants that scope. It's very important.
What are the symptoms of a hiatal hernia?
So the hiatal hernia, in general, the most common thing that is going to happen is that you're going to have reflux. So it's just going to make you much more prone to having acid reflux. That's the majority of patients. The hernia itself rarely causes issues. People usually don't feel it when it's small. When it's big, sometimes people will have a feeling of like an occasional pinching sensation, which can be severe right over here underneath their breastbone. Sometimes people will have a problem with, if it's a very big hernia, after they eat, getting a lot of chest tightness, okay? Those are big hernias. So big hiatal hernias, you're gonna have much more symptoms. Vast majority though, of your symptoms are just gonna be, you're the kind of guy that's gonna have a lot more heartburn than someone without a hernia.
The hernia is right here, right?
Right here, right below your breastbone.
Just reach in and just put it.
You know, some people, there are maneuvers that some people talk about pushing, trying to push their hernia down temporarily when they feel it gets stuck. There's abdominal physiotherapy that people can sometimes do for that.
From the chat, someone asked, could you explain H. pylori?
Yeah, so it's a great question. H. pylori is a bacterial infection of the stomach that can cause belly pain, can cause ulcers, and can increase your risk of stomach cancer. H. pylori itself is not quite clear if it leads to or worsens acid reflux. Most people, most experts suspect that it can, if you have H. pylori in a certain part of your stomach, it actually makes you more prone to having acid reflux. So H. pylori is always looked for in patients that have heartburn that doesn't really completely respond to therapy. As they're saying, well, do we have H. pylori contributing here to the symptoms? And H. pylori can be looked for either with a scope or with a breath test or with a stool test. So for patients that have heartburn or, you know, food pain after they eat, or belly pain after they eat, H. pylori should always be looked for. And it's very treatable with antibiotics. Sure, we'll start.
So the PPIs, as far as long-term use, what's considered long-term?
Yeah, so in general, most people will say long-term is sort of more than a year of therapy. So I know a lot of people and a lot of my patients, and a lot of patients out there are actually have been on these medicines for decades, 10 years, 15 years. And those are the patients that, it's really important sometimes to just sit with your doctor, your gastroenterologist, and say, hey, what's my status with this? Can I get off this? Have we done a trial to see what we can do? Is my body different now than what it was when I first started these? So it always is important to get addressed. So long-term use, again, there's no consensus, but usually we start talking about over a year, of consistent daily use. And then remember, the high dosage is 40 milligrams, usually twice a day. Okay, so the lower the dose and the less frequent, the less likely for any of those risks. Someone said, yeah.
I have a couple of questions. I've started taking apple cider vinegar.
Okay.
I wanted to know the benefits of that with GERD, and then what are some possible damages to the esophagus?
Yeah, that's a good question, and we're getting that a lot more. A lot more people are using apple cider vinegar. I was actually just part of a panel of discussions over at Northwestern. It was a Zoom meeting where, the nutritionist actually gave part of the talk and talked about apple cider vinegar. And I think the short answer is our data is lacking in terms of scientific, evidence-based data in terms of the role of apple cider vinegar. Now, anecdotally, meaning like just our experience with patients, a lot of patients will actually say that they feel benefit, that when they do the apple cider vinegar, they actually get some relief. I just don't have the data to sort of support its use. I don't know how effective it is in preventing some of those complications. I do know that it's generally safe in terms of its consumption that I'm aware of, but in terms of its benefits in preventing some of those complications and how well it works long-term, I just don't have the data. So right now I'm telling my patients if your symptoms respond to it, by all means, continue that. If you're getting 100% relief, go for it, you know. And my experience, most patients who have severe symptoms, it's just not going to be enough, you know. But the milder symptoms are intermittent and help.
Okay, but there's no damage to the esophagus with it.
Not that we know of, yeah. Not that we know of.
And then the last question I had, was the increase in acid in the stomach, is there a correlation with gas buildup?
Yeah, so like
What is-
bloating and gas. So usually people who have, you know, the gas or the acid buildup and the acid of reflux, it doesn't impact anything sort of lower down in and of itself. So most of what you're gonna feel is gonna be above your stomach, the chest, like I said, the throat. What ends up happening though is patients who have a lot of acid, who are taking a lot of medicines for it, like those proton pump inhibitors, that can then lead to more gas production because it can alter your gut bacteria. So long-term use of those PPIs can then alter your gut bacteria, which can then lead to bloating. So that's where I think that big link occurs.
What's a PPI?
Sorry, proton pump inhibitor, that's that class of medicines that, like your Nexiums, your Prilosec, your,
Yeah, that's what I wanted to ask you about. Is that time frame? Because I take a moprazole,
Omeprazole.
and I've been taking it for quite a while. Is there time frame that, like Nexium, they used to say that you're not supposed to take it more than 7 days or 12 days or?
Well, the duration of, it applies, like if you look on the box that you get over the counter, it will say, you know, don't take them on 14 days or 7 days. But no, it's how your doctor prescribes it. So for example, if you're taking it for reflux, that's frequent. Your doctor will prescribe it, sometimes 3 months at a time or a month at a time. You know, so it varies. The box is just for the over the counter, but really it's your doctor that's going to tell you how long.
If you are using a PPI
Uh-huh.
and your bacteria has been altered, will a probiotic help at all?
Yes, definitely. So that's our first step. A lot of times is to, if we can't get you off the medicine, put you on a probiotic. In severe cases though, we'd have to eradicate your gut bacteria that's already there. So we'll usually give you a non-absorbable antibiotic first, get rid of the bacteria that's there, and then slap on a probiotic afterwards to try and help rebuild the normal gut bacteria.
What's the going in number for the flora for the probiotic?
Yeah. So each probiotic has what differs from probiotic is the type of bacteria, one, and so those are things like Bifidobacter infantis, Saccharomyces boulardii, Lactobacillus, and then the CFU, colony forming unit, that tells you how much are in there. So the CFUs, I think, are less important than the type of bacteria. So for gut issues, you want a probiotic that has Bifidobacter species, okay? There are a lot of probiotics out there right now that's, you know, not all are the same. So for GI ones, you want to look at the back and make sure that it has Bifidobacter species, and that one should be good.
You recommend a pre and probiotic or just the pro?
Yeah, for the bloating, the prebiotics are going to be a little bit of a different scope. I don't usually recommend the prebiotics. I work predominantly with probiotics when we're dealing with intestinal bacterial overgrowth, and those are where most of the effective data come from. So we're gonna fix that.
Shotsky's ring is a scar tissue, can that lead to Barrett's?
No, it's completely benign. Shotsky's rings are great because we could fix them with a scope. We could stretch them out easily. They're completely benign, and they have no chance to turn into Barrett's or cancer. So when we find them, if someone has food getting stuck, we do the scope, and when we find it, we say, "Whew, okay, great, this is not cancer. This is a ring of scar tissue or fibrous tissue that we can disrupt very easily." And those patients do great with the dilation, stretching out.
With chronic coughing and acid reflux, you had mentioned that it's a dry cough. Can it be a wet cough too when we do the acid reflux versus allergies?
Classically, it's a dry cough, you know, so the wet cough usually means a productive cough. That means you're putting up sputum or purulence, and in general, wet coughs tend to mean more sort of issues with the lung tissue itself, whereas a dry cough is usually referring to sort of the reactivity of the airways. So classically, it's a dry cough. But the cough can be tricky because then you have to work with your
I
your
know.
lung doctor, and say, hey, so that one's always tricky. And those patients don't respond as well to treatment, those can be very hard. Very hard.
What did you say about the vinegar? Vinegar.
Apple cider vinegar, and then it tends to work in some patients. I just don't have I don't have data, to know how effective it is.
With a little water or something?
Some people will dilute it, sometimes it comes, the way it is, but I don't have data, so I don't usually prescribe it to my patients, but my patients who are on it that say that it works, I say, I go for it. Just because it's safe. Yep.
Are the surgeries covered by insurance and Medicare?
Yeah, so you have to, if you meet those criteria of those tests, it's covered, it's covered by most insurers. So
it has to be justified, huh?
and yeah, they have to confirm that you have reflux, they have to rule out other things. So those testing that we do are mandatory for the surgeons and is also for the insurance coverage.
Okay.
So if you take Rolaids and it only happens to you every so often, is that okay to just?
Absolutely, yeah, if you have reflux every blue moon, pop a Rolaids, that's fine. Yeah, that's completely okay, but if you find yourself popping a Rolaids, 3 or 4 times a week, or if at any point you have difficulty swallowing, food getting stuck, then that's when you gotta talk to your GI doctor, probably escalate therapy, get a look.
But as far as PPI is going, going on and off of, as far as like saying, hey, I don't feel like I have symptoms, is that at some point, somebody said, oh, you really shouldn't do that?
Yeah, so PPIs are not as good as sort of like famotidine or those H2 blockers where you can just take it as needed off and on. They're meant to be taken in courses. So let's say you get bad reflux, that's pretty consistent. You take it for 2 weeks, okay? If it's, 2 weeks, even if you're feeling good,
Yes.
you take it every day and then you stop it, okay? That's one approach to using PPIs for reflux. That's more severe than what you would use the Pepcid for example. So you do 2 weeks, you do a course, not just, you can, you try it as needed, meaning just a day or two, but most people will recommend, because of the way it works, that you take it for at least, a week or 2 at a time.
I mean, say you've been on it for 2 years, or just a year,
Mhm.
and then it's hard for you to say, okay, let me just test this out. So you can go off them, and then say, okay, this isn't working, you just go back on them.
Absolutely, yeah, yes, you can do that. Yeah, you won't get immune to it or anything like that.
Right, okay.
You gotta cut back instead of daily or every second day.
Yeah, definitely. I mean, talk with your doctor when you make that change, but yeah, you can do that. You can take it every other day. You can take half a dose, and the goal would be to take as little as necessary.
I'm taking 20 now.
Yeah, so that's a low dose, so 20 is the lowest dose. So that would be something, if you wanted to go lower, you would take every other day, for example. But definitely talk to your doctor before you make any changes. Anybody else?
I know it's probably minor, but sometimes when I get heartburn, it's like if I drink a lot of water or Gatorade, that seems to help. So if you drink like a lot of water and Gatorade, would that kind of help the heartburn stay down?
Yeah, what's happening is you're flushing the acid down. You're trying to just flush it down, neutralize it, dilute it. And so that's where things like water, a lot of people say milk, because milk's a little bit more basic, might potentially.
Milk would be better.
Oh, yeah. Some people, that's their go-to, is that they'll drink something like that. But part of what's happening is you're flushing down the acid, you're diluting what's in the esophagus.
Because I would think clear juices would probably be best or something like that. though.
Yeah, I mean, in general, the more basic, the less acidic. So definitely you don't want to have like orange juice or anything like that. But most of the times milk or water, if you have to choose something.
And
that's gonna be
Gatorade,
better.
okay too.
Gatorade's okay, but some of them, again, with that high fructose corn syrup that's in there and some
Oh,
of the
because I would think with the electrolytes and that would be.
electrolytes have no effect. Yeah,
Oh, no.
yeah, the electrolytes won't have any effect on neutralizing the acid.
The last procedure you were talking about,
The tip?
you're stretching something. My mother-in-law was having trouble with her food not going down.
Uh-huh.
And she said something about she had to go in to get her esophagus stretched.
Yeah.
So is that something you covered or is it?
Yeah, that's called a dilation. That's whenever someone has food getting stuck, if there's any narrowing of the esophagus, we look to see what's causing it and potentially stretch it out if we can. And that's called a dilation. We use balloons most of the time to stretch out that narrowing of the esophagus. Very commonly done.
It's an endoscopy.
It's an endoscopy, yeah, it's done with the scope.
So that's something different from the other things you covered.
Oh, yeah, that's done for people who have narrowings of the esophagus.
Okay.
Do you have any good books to refer for that? by any chance?
About reflux and things like that?
Yeah.
I actually don't. It's a great question. I can look into that. You want to pop me an email? And then let me see if I can kind of see what's out there from my colleagues in terms of patient-friendly books on reflux and how to manage it. I'm sure there's definitely some out there.
Because I already put some books on the counter there, I don't know if you saw that.
Oh, okay, all right. Oh, look at this. All right.
Usually when they program. they sample
Okay,
that.
that's nice. Okay. This one I haven't heard of. This one I've heard of back here. This is a more of a how to cook and a diet and like recipes for people with reflux. But I'll look to see if there's other stuff talking about the meat or the heart of reflux. Most of what you're gonna see out there is kind of like cook and eat for reflux. You know what I mean? So,
Okay.
guys, these were all great questions.
Thank you.
I appreciate
Thank
it.
you.
Thank you, guys. Like I said, shoot me an email if you have any questions, all right?
Thank you.
Thank you.